It's my great pleasure to introduce our guest speaker today, who's visiting from Croatia and has been spending a bit of time in Ontario, about 10 days or 2 weeks, getting to know the health system and making some connections here. And the NAO is really delighted to launch our fall term of the seminar series with Aleksandar Džakula. And Professor Džakula is from the University of Zagreb in Croatia and an active participant in an international network that we're also involved in called the Health Systems and Policy Monitor, which brings together health policy researchers from across the European region and beyond. And so we've had a chance to meet and collaborate on a few things, including Hussein on some work as well. So in addition to being interested in comparative health policy and systems, Professor Džakula also has a rich program of research on integrated care, palliative care, the role of nurses as enablers in integrated care, and studies health system reform from a long period of time, as indicated by this lecture title. It's very ambitious. So we're really excited to hear your thoughts today and then to have some discussion about some of the shared challenges and opportunities that we could learn from Croatia and vice versa with Ontario. So turn it over to you, and then, yeah, we'll keep the recording on, but we'll, we're fortunate that you're here in person too. So over to you. Thank you.
Okay, thank you. Thank you for the opportunity to be here with you and the opportunity to discuss with you what I expect and I would like, because during the next 10 days, I really have very nice discussions and visits and very useful. My lecture was changed according to these findings, conclusions, and I have to kind of check up this morning with Hussein, and I realized, okay, I'm more or less I'm in line. What is something interesting here in Canada? So as Sarah said, I'm from Zagreb University, so I have experience doing as a professor, but also we do many projects to implement some changes in the healthcare system, having in mind that we have many problems and many weeks in the system, so challenges are higher. So, but the reason why I decided to present this lecture is that we really are in the country that passed extremely or so many changes during the last 100 years. And the question is it something that we can use to check? Some countries have tradition, we have changes. This is something what is completely different. Here I'm talking about health and the community, and my first steps in my profession was with healthy cities, with Ottawa Charter, with healthy community, health promotion and such stuff. So it's the same what we have in a country in Croatia with primary health care, and this is a list of magic words. But question is about the changes, about what we have in this setting, what we have in these social units. Is there something what we really can transfer to conclude something out of this? Because as you know, we truly believe in the power of family, we truly believe in the community, we repeat it all the time, empower them, because social determinants of health, because all these impacts we have, that's what we need to promote. And the question for our team was, are these concepts that we have at the moment, like hospital without walls, or ex-mural hospital or integrated care, is there something in common with our past and with these magic words? I will tell you that we had some expectations, and I'll show at the end that during the last 5 years, we a little bit changed our practice because of our findings. So you'll read it and tell me, is it Canada or Croatia? I'm not going to read it. If you can select one to Canada, one to Croatia, doesn't matter, but it's the best.
Canada.
Canada, yes, that's true, but and Croatia is true. It's completely the same. I was surprised reading this, and I said, "Oh my gosh, it is something what is could put on the same slide, and this is something what's common. What maybe makes this my mission to Toronto and also possible future cooperation possible and feasible because we have same problem but in different settings and backgrounds, and that makes maybe some chances to do comparison what is our basically starting point for the, but of course many similar same problems, but differences are also there are not only because of money or because of economy, but you can see life expectancy and then the spending per capita in the modern world when we have common goods with same prices, amount of money has significant impact. But last, the third one, it's mortality rates. I'm very sad about it because we had very good medicine and good medicine, good medical doctor, and available drugs do not provide result. This is a crisis of efficiency, and that's something what really makes us sad, that with existing resources we do not provide outcomes that really is something what matters in healthcare. So you see, Canada and Croatia have a lot of in common, and in primary healthcare, integrated care on this level, but efficiency in this system is much better in Canada, and this is something what we would like to maybe study better. But what we're talking about is this experience Croatia has in the past and these 100 years and what happened behind. And this Europe is, we start discussion right now about the Europe former Yugoslavia. What's East, what's West? Is there something that matters? So for many reasons, we have discussion all the time, unfortunately, and because of the war in Ukraine at the moment. And you see various analyses performing differences between East and West, including that some countries were former in a Soviet bloc, that means under the socialism or communism as an ideology, or you can divide them in Eastern Europe, red, yellow, Mediterranean, green, some Western or Scandinavian. Whenever you want, you can divide, and there is real differences. Also, if you would like to see, we discussed this relation between the religion and the national identity, or you would like to recognize themselves as a superior to others, this blue graphs, so many differences you have in Europe, and be very proud about our differences, of course, but doesn't matter what it means that we are proud in reality. Also, in healthcare, I selected life expectancy on the top. You see huge differences. Unfortunately, again, on the right side, you have most of them are Eastern European countries with a lower life expectancy. Also, the care expenditure total amount also lower in Eastern Europe. This share also is down. This is a legacy of some previous systems, and although some have very effective system at the moment, but still there is a lot of space for improvement. Of course, some Western Europe country would like to decrease expenditure and such stuff, thinking about what we do in Eastern Europe with less money. So that's what Europe is in some numbers and in the maps. Also, there's a third perspective, and when someone from the outside compare what we had in the past and now, this economic development, democracy, liberal conservative values in the past or nowadays, but then religion is very important in Europe, not only for community, but the states. It's this kind of national churches and national identities. And then, of course, model how the system is organized and paid, Bismarck Beveridge or Semashko with industrial concept of providing healthcare. Altogether, we have these impacts, and we made some decisions regarding all what you could see here. And nowadays, when we discuss, always have some rules. Some will tell them, used to say, well, we had in the past this, it was good, it was great, let me go again, and so on and so on. But I'm not sure all what I showed you is absolutely true, but also is it really relevant? There is impact, but how that this relevance is really powerful, you need to detect again. If you would like to have arguments about anything, you can find it but I'm not sure that's enough to really make a right decision. This situation makes crazy decision making in public policies. Okay,
So you
better?
can see your face.
Okay, thank you.
What do you mean by the bottom Bismarck the system?
Bismarck system is social insurance model. Beveridge is a UK model. Bismarck is a Germany, Austria. There were the roots and spread around Eastern Europe, and some Italy have similar like that, but partly it's more Beveridge. And Semashko was from Soviet Union. Okay, it was like industrial with hospitals as the key providers of healthcare. But 100 years, during these 100 years, we completely changed why we have healthcare system, what the priority are, what the target groups are, and you can see kind of evolution. Who were the first? There were farmers, then we moved to the workers, then active patients, citizens, war victims because we have war, homeland, the world wars, also elderly, complex patients. Every 10, 20 years, we completely place a new target group in front of us and say, wow, now we have them. We would like to work something for them, to include and improve some programs for them. But also communities, it's also interesting in the healthcare. First it was rural, then suburban with some workers' poor conditions, but then industrial setting was extremely important. During socialism, we had completely developed the medical care in the companies, because workers are the top class and we would like to provide everything to them. After that, there was a war victim veterans were in focus, and then it goes. So every time we have some changes, and these changes, of course, have direct impact on the allocation, the target group, target community, and the way how you treat them, and then that makes some reforms necessary, but sometimes impossible. Because it's not the same. You have politically defined target group, and the reality for the reform is different, and then you cannot merge it and could not have sustainable. And primary health care, we started with public health, with hygiene, and then MD, general GPs, then health centers, family medicine. Evolution was there, but with the evolution of the profession, there was decrease of management and evaluation. What ends in the very weak primary healthcare and disintegrated, fragmented, and so on. So if it's confusing, it is. It is. Everything is on table at the moment. That's why decision making. What makes our team very frustrated, and but it wasn't everything local, and we have some nice stories in our region. Unfortunately, before the nice stories, we had 3 major wars in Croatia in the region. First was the World War, the first, the second, Homeland War. Then we have completely changed political settings during 4 phases. Then we have many reforms and priorities, as I mentioned before. All together made the comparisons, healthcare management, completely crazy and very difficult, especially using the tools and approaches that we have here. So I'm was very frustrated for the first 10 years of my career, because everything was on the table, everything was right, everyone was right. And the question is there possible to do anything what have a structure, goal, and is there something what we really could change? Good story is that we had this man. Aleksandar Džakula was born and lived in Croatia. He was, as you can see, the first president of WHO Assembly, and he wrote a constitution of that, absolutely present all around the world. He was in China too, doing great projects in the 30s through the League of Nations as their representative. So we have knowledge, we have people. There also was the power to change, but all these circumstances and changes, they disrupted some systematic approaches, and maybe the change of my approach to the healthcare system and to this chaos was when I read one sentence, and the sentence that may be really common to you. This is something what talks about segment of healthcare. because I think that there are some changes, or there are some systems where everything is structured better and with changes that are going. So this is about America. I think that you agree with what's written here. For this America means United States. It's in Croatia, when you say America, means primarily two states. Canada is Canada, state. But look, this certain sentence with some more information. So then I start to read the documents, first 20 years ago, documents that are not regularly communicated. Then I start to think about the analyzed documents 50, 40 years. And then we detected, oh my God, these people all the time using the same lens. The setting is going, the setting is changed, same lens, provide you chaos in your head. And then from the chaos, it's not easy to do something, and something lasts like 100 years. Obviously, we need to rethink, use different lens. So 100 years of experience, even so rich, not necessarily good news if you do not have the right tools. Or if you use something what all the people use, and you can only cry and have chaos. So lessons learned. Is there something that we can say, yes, this 100 years is a value, and we can teach other people, we can conclude something, and we can go going forward? This is my challenge for me, because I'm a professor, at least. What I'm going to tell students, you know, sorry, this chaos, we can cry together or alone, or we can schedule every day other people, someone else will cry, and that's it. But that's not my philosophy. I would like to fight. I would like to give some results. So I'm not looking for the lessons learned deep in that. First, what we decided to rethink was this magic word, family. We all talk about transition on family. It's not transition. It's completely different entity. Completely different entity. Still extremely important for each of us, but it's completely different. This word is only the letters are the same, and importance. So there is a bug. Whenever we talk about family, think that maybe this family that you're talking about is somewhere from documents from the past. Someone has this mind concept that do not works anymore. This is the first thing that we need to rethink. We have family medicine. If it's so dramatic change, is there a dramatic change with the family medicine? I'm not sure. The second word we decided to think is community. What I did from the existing definitions, I've tried to withdraw or take some key words that maybe better fits what we have now as a community. In a community, we have a romantic idea of community. We live together, we support each other, it's very interesting, we enjoy it, and it'll be a nice future. We'll have cycling roads around and barbecues and gardens, and that's community. Yes, it is. But look what is behind its interest. There have to be something in common, that because if you would like to really implement something, what's important, what's hard to work, then this romantic story is not good base for such a system. Healthcare, social welfare, palliative care, it's heavy work. You cannot place it somewhere where there's a weak, very romantic, poetic fundamental structure. That's why we need to think the community. And then thinking about family and community and the people, there was only one word that we detect that is constantly all the time here, very clear, and that had to be the first, the word needs. Forget the wars, churches, political issues, structures, Bismarck, Beveridge, everything. First of all, think about needs. and ask about things. So often we skip this question. So often we go forward to think about solution and then go back to see why I can fit with my solution. I have some kind of joke, what I used to say when I'm coming to some institution to do consultancy. I say, oh, I'm sure that you have a real situation. You have a great solution, but your problem is not so good. You need to fit your problem to your great solution. That's philosophy of our managers. That's how we think about our great ideas. The meaning of needs and position of means in our thinking and planning disappeared. This is the first conclusion out of 100 years. In 80s, it was crazy in Croatia, I can say, because we ignored needs, but we have some solutions and try to fix some new solutions. And during the 90s, again and again, without asking, what's wrong? What is our need? I like very much this diagram or figure at the right side, because you see this overlapping, this necessity. You need to have in this diagram that your needs are aligned with demands and supply. We're suffering a lot, and we had a huge problem with this in the history during these 100 years. Every time there was like rings on 3 different sizes. Nobody can organize system if you have 3 independent rings: politicians, industry, and patients on the other side. So whatever we do after 10 years, we analyze some situations from the past using this tool. That's it. Every time when there was a crisis, we had these circles completely split and pushed away. That's why we need that needs are something that first lessons learned always ask about needs. It sounds so simple. It sounds so basic. It's written in every handbook. But if you really analyze the documents, thinking, though the needs link the results and actions, you'll be surprised very often. Generally speaking, it's okay, but inside, for the implementation purpose, I'll tell you a little bit more about this, there is a huge gaps. Your wishes are not something that fit to the needs. Implementation and outcome is something what could be directly linked to this. Okay, so this was the first lesson. The second, community is not institution. It's ecosystem. It's alive. Doesn't matter. You're in socialism, capitalism, during the war. It's alive. It happens. Changes are ongoing. So it's like a river. You have to swim inside, not simply be there. Also the healthcare system and social welfare. You need to swim again and again and exercise how to swim in different settings. That's why you need to be participatory. Of course, community has many resources. Saying this morning we discussed about we have resources, but if you don't understand this ecosystem and you cannot recognize this resource inside the community, your intervention only pressure to the community, not support, but you need to detect these resources. Otherwise, what happens very, very often, your resources in the community will be a barrier for change and for implementation. And your effectiveness will be going down, efficiency to the catastrophic. Of course, relations and process. You have people in need, you have resources, but if you don't understand the relations and process, what's going on inside, you only could collect extra resources in some way to try to present something you're doing, but without precisely defined piece of place intervention, it will be really catastrophic. Lesson 5. People do not live optional life. They live 24/7, especially when they have a problem. But inside that, you have specific personal and community needs. Not something extraordinary. Very often, very simple, but specific. Detect them. You can spend hours, months, years, and huge amount of money to really miss what is a specific need. And once when you have your resource, it doesn't match what Point 7. The best not necessarily means the best outcome. The best input not necessarily mean the best outcome. As I said, we have great doctors, cheap, free drugs, good hospitals, poor outcomes. What's wrong? Something was going on process. It was very frustrating, to have all this and invest more and more money, thinking that the new building will solve the problem. No. Bigger building and more money will only cause bigger problem, nothing else. That's how it works. But I would like to do some change management. Have in mind, communities are not institutions. They live and survive, but they cannot manage the change. You need to provide them change management very carefully. Very carefully. Shortages are what we live. There is no community with enough resources. That means, first of all, try to fix where the critical gaps are, where the bottlenecks are. Because very often there is a bottleneck and we cannot pass it to your resource, existing resource. We discussed this morning a little bit about informal care and such stuff. We have some people there. We have them around, we have money, but there is a bottleneck. Stop, check, because if you have that, you have disaster. What else? Your great health policy, your great calculation analysis could be go to catastrophic end or finish if you miss some bottleneck. And finally, even the weakest community is the partner. The weakest possible is a partner. Once when you do this asymmetry, that they are not partners, that you provide them something, this end of your story. Immediately, you will end your mission without outcome, and even there will be conflict, even if they are weak. So, we have great conclusions. The question was, what now? And then, almost 10 years ago, we start to group people and team to see, okay, this is very fine academic conclusions. And we can find evidence about it, we can publish it, but we need to do something in place. People invite us or say, okay, I will believe you, but do something. And now I'm going to present you some more academic background that we can discuss later about it. What does it mean? That we have even deep paradigm changes, modern and postmodern philosophy, I can say, and paradigm of healthcare. Nowadays we live in digital. This is something that happened after and during these 100 years. Standard benchmarking, we need to move to bottom-up system, there is community. We need to do process improvement. We need to do integrated care, apart from the basket that is paid. And finally, projects could not provide sustainable interventions. So these were our inputs for our change, for what our team is going to do. To use this 100 years of experience, use these inputs and say, okay, there is something what we can do. So what we did as a result. This, who we are think tank, one professional community, 5 to 15, 20 people working together depending on what our task is. And we provide assistance, consultancy, or policy documents for the local level, national level institutions, trying to pilot some change. The biggest change we did was palliative care. We developed a national system of palliative care. So we first in the world designed on the integrated care model from the scratch. We completely designed the system of palliative care without any new institution. No new institutions, but only existing resources and only one coordinator. So we only implement 43 persons were new, everything else is existing resources based on our philosophy. And we also developed some concepts and tools. First was how we approach some policy intervention practice or looking for the best practice. Professionals would like to use scientific evidence and professional practice, but someone who operates as a manager would like to use legal and it works as a business model. But even if it's proved by science or professionals and legal and that could earn some money. The problem is setting society. Could society accept these values you promote? And does the people will participate? Without this component, your policy will stop. I cannot say die, but will stop. It's very simple tool. We have a list of questions based on that. And you can compare various communities where the problem will be with your policy if you're going to implement that or work with that. The second change we did was this. In the past, we had simple triangle, primary, secondary, tertiary care, and well-known gatekeeping. What's gatekeeping? Nobody knows, really. Or everyone has different definition. Gatekeeping, keeping what? We want more integration, and we have gatekeepers. What they're doing? The locked door or the open door? See? But we say no, forget it. We say citizens, patients, then your friends, families, neighbors. Then you have social welfare, public health, and then mobile teams, patronages, nursing care, home care. This is concept for Croatia. Then we have physicians and then other concepts. We broader space around the patient because it's more effective, more efficient, and it's everyday life. Doesn't matter which clinics do you need. You still have your friends and neighborhood, and you need it. You will leave hospital. Where will you be? You're back in your neighborhood. This is the second model we used in this concept.
Sorry, what's THC?
Beg pardon?
What's THC and SHC in the
THC, tertiary healthcare,
Oh,
clinical level, very specialized care. This is very popular in Europe to divide in primary, secondary, tertiary care, because who is in tertiary care thinks he's very important. This is one of the reasons why we promote this concept. The next level was we detected the paradigms of intervention during the last 10 years. There was a colonial. We have power, take our knowledge or die. We have best products, buy it, or during the 90s, we have so many experts, they recommend you have to do, you should do, and so on, then leave. No, that's not something. We think if you really want to do some change in community overall healthcare system, you need to have knowledge and knowledge. That's what you do. But you have to work together with people, partners, and real-time intervention. We call it digital decision-making in approach. And finally, check the real needs all the time. This is a new paradigm. And nowadays, people who develop strategy or policy documents in the same time have to be someone who participate in the implementation. In the past, they were divided. Analysts, policy developers, and someone who have to implement. Nowadays, we think in our team, we work all together. Because when you start to do some analysis, something is in place, some implementation from the past. First, we need to think to understand what is implemented, what's not, and then go forward with that. That's how we work. It's our, I can say, philosophy, our company philosophy, our company mission.
And also, I think money.
Okay.
Money. Every good healthcare system requires money. So if you have a good idea or the goals, if you're economically is not feasible, then it's hard to implement.
Money is a fuel. It's not a car, not a machine. And you need fuel. But if you have money, if, for example, all your people in hospital are paid, they have salaries, they have drugs, they have equipment, and you have poor outcomes, obviously money is a problem. If you have too many doctors and nurses, what we have in some hospitals, what to do? And poor outcomes, money is not a problem. So it's very interesting when money is not a problem, what to do? It seems that the money could solve the problem. No. Money can be part of the solution, but money is not. When the money is problem, there is no problem. That's the rule in the system. Money is a fuel. Simply add money and it will run, but I'm not sure. Just for example, we analyzed waiting list for the hip replacement in Croatia. We did a few months we spent detecting all what the problem. We detected. All the physicians told us the money is problem. Give us money. It was all of them. There was plenty of them. Big bosses, big managers, MDs, doing the positions, having position on a higher level in the tertiary care. All of them told us money, 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 money. We say, okay, what will happen if we will give you money you ask? What will be barrier? Then we force them to present us what barriers they really have. Talking with each of them, we collected 24 barriers or bottlenecks that will block them to operate better, even with more money. When the money is problem, there is no problem. And finally, on the policy level, we developed Policy Coil. It's a simple tool that in some way easily enable your partners and your, for example, communities or politicians to participate with you in policy process, simply doing data from the reality and from the outside evidence like scientific papers, to go to the policy coils, continuously prepare decision, repeating and have real-time decision-making. It's very popular. One day where you need some brief recommendations. It was very important during a pandemic because immediately you need to produce some decisions to do something. And then these tools are very important that you can in some way record what you did yesterday and what was good, what was not, and what were inputs that changed your model and the paradigm. So at the end, I showed you these three tools, the policy coil we use for policy documents. That's how we work with our partners when we have to consult them, and how we, I can say, map the community and what we have in primary healthcare, and how we look on the policy implementation and overall to detect in which perspective maybe our solution will not operate properly. So it was my presentation. So thank you very much. I'm here for your questions. It was about 100 years.